Hello and welcome to an introduction to ECMO. My name is Michala and I'm one of the perfusionists here. This presentation is designed to teach the very basics of ECMO. We will go through the various parts of the ECMO circuit as well as its uses. Some of you have already caring for ECMO patients, so for you this will be review. However, for many of you this is a true introduction before you're responsible for caring for ECMO patients. ECMO stands for Extracorporeal Membrane Oxygenation. ECMO can act as the artificial heart and or lungs for the patients. It can allow the heart and lungs to rest during healing. It can completely or partially take over the work of the heart and lungs. When you see ECMO written, it's usually V-A, V-V. The letters before the dash denote from where the blood is being removed, and the letters after the dash denote from where the blood is returning to the patient. VA ECMO, blood is coming from the patient on the venous side and is returned on the arterial side. And VV, blood is taken from the patient and returned on the venous side. How is this achieved? Blood is pulled from the patient via the venous cannula and tubing by the centrifugal pump head. CO2 is removed via sweep settings on the blender. O2 is added and controlled by the FO2 settings on the blender, and blood is then returned back to the patient's circulation via vein or artery by the pump. This slide is included as a review for those who may require it. Here we see the most basic of ECMO setups. VA ECMO provides both gas exchange and circulatory support, pulling blood from the venous side and returning it to the arterial side, thus bypassing both heart and lungs. VV ECMO provides gas exchange only. Blood is pulled from the venous side, goes through the circuit, and returns to the venous side. So it's still going through the heart and the lungs, but a lot of the work of the lungs has already been done. This slide shows an overview of the ECMO circuit. We actually have 3 different ones here. This is probably the one you'll see the most. We also have an older one, which we will use if we have to, and a newer one, which is called the CardioHelp, which is more portable. So from the top of the slide down, you can see the gas blender, the flow controller. You can somewhat see the oxygenator and the pump head, and you can see the heater and the water lines to the heater, and the emergency hand crank. This is the flow controller. This will show you how fast your blood is moving and how fast the pump is spinning. Here we can see 4.15 liters per minute is how fast the blood is flowing. And the pump has a rotation per minute of 1,366. This is all controlled by the dial below. Turning it up and down will increase and lower your RPMs. Here we see the pump head. On the left is what it would look like when it's attached to a patient. Of course, it's full of blood. And on the right is what it looks like without blood in it. There are blades inside, which we call impellas. Those spin. The spinning motion pulls blood from the top and pushes it out the side. This is the quadrux oxygenator. This is where the gas exchange takes place in the ECMO circuit. Can't see the gas port on this picture, but that's where the gas line would actually be attached. The yellow venting cap we can use if some small bubbles happen to be on the pre-membrane side of the oxygenator. Where you see the blue cap is where the blood goes into the oxygenator, the gas exchange takes place, and it comes out where you see the red cap. At the bottom are 2 ports that we attach the heater lines to. The heater lines are full of water. When we heat the water, it then allows us to heat the blood. This is the gas blender. Gas blender is connected to both air and oxygen. As you know, air alone is 21% oxygen. Thus, blending in pure oxygen allows us to adjust the percentage of oxygen that is delivered to the patient's blood. This is set with the FO2 dial. The sweep settings determine how fast the gases are actually flowing. The sweep rate is what is responsible for CO2 removal. Think of sweep like the patient's respiratory rate, or ventilator minute volume. The faster the gas flows, the more CO2 that is removed. Like respiratory rate, the faster you breathe, the more CO2 you blow off. If the sweep is turned off, then there's no gas flow whatsoever, much like if you were to hold your breath. So during a sweep trial, when we're trying to see if a patient on VV ECMO is ready to come off ECMO, we turn off the sweep, which means there's absolutely no gas exchange happening in the blood. This is the heater. This is how we heat the patient's blood. If we didn't have the ability to heat the patient's blood, they would get very cold because they have a significant amount of blood outside of their body that's going to cool down to room temperature. This is our CardioHelp system. This is the integrated circuit, which is great for mobilizing patients as well as transporting patients. Although it looks different from the last circuit I showed you, it has all the same components. This is the oxygenator that we use in the CardioHelp circuit. Although it looks different, it is actually the same oxygenator that is used in our other circuits. This one's red, the other one's white. The big difference is that the centrifugal pump head is attached to the back of the CardioHelp oxygenator. Because of this integration, it makes this a much more mobile circuit. This is what the user interface looks like on the CardioHelp. Again, it's a completely integrated system, so it's actually attached right next to the pump. As you can still see your blood flow and your RPMs. You also have the ability to see your SVO2, which is great for trending, but is not 100% accurate, so it shouldn't be used for treating the patient, but it is good for seeing trends up or down. On this slide, we can see common cannulation sites. For access, usually we'll use femoral vein or subclavian vein, internal jugular vein, or even the right atrium. For blood return, quite often you'll use a femoral artery, axillary artery, the aorta, or pulmonary artery. Distal limb perfusion is used in VA ECMO patients who are femorally cannulated. The femoral arterial cannula is placed so that the blood return of the patient is flowing retrograde or opposite to natural flow. So it's going up the aorta instead of from the heart and down the aorta. The size of the arterial femoral cannula can block the arterial flow from reaching the distal limb. So a smaller cannula is placed such that some of the arterial blood is diverted from the femoral cannula in order to perfuse the distal limb. If the arterial cannula is completely blocking blood flow, then you won't be able to palpate a pedal pulse. However, with this smaller distal limb perfusion cannula, you should still be able to get Doppler pulses. But if the line is kinked, there's potential for limb ischemia. We have no way of monitoring how much blood is flowing through the distal limb perfusion line, and it's a very small line, and because we can't actually monitor the flow, then there's not going to be any alarms if the flow stops. So you have to leave the distal limb perfusion lines uncovered, because visually is the only way you can tell if they're kinked. And if the lines become kinked and it's not noticed, then the limb has the potential to become ischemic. This slide shows the various ways you can cannulate a patient for VA ECMO support. So what exactly are we asking you to monitor? Your hourly checks, as well as any time patient is repositioned or transferred, of blood flow, which you're going to document your liters per minute and your RPMs, gas flow settings, so your sweep and your FiO2, as well as the circuit integrity. So let's go over some of the changes that you might encounter during your checks, what might be causing them, and what, if anything, should be done about it. First thing we're going to go over is your blood flow has increased from where it was set. This could be due to decreased vascular resistance. So the pump doesn't have to push quite so hard in order to get the blood out of the circuit and into the patient. This could be through vasodilation, maybe the patient has a high temperature, or you're weaning the pressors. It could be improved arterial cannula position, maybe you've just turned the patient or repositioned them. Also could be because the arterial cannula fell out and there's no resistance. It could be a blood leak at a connector or a tubing site. It also can be increased circulating volume. So maybe you've just given the patient a bolus of fluids, or they're getting a lot of medications or have a lot of IV drips. So they have increased filling. The improved venous cannula position as well can cause this. Opposite to that is the blood flow has now decreased. So the opposite again, increased vascular resistance. Maybe you're having to go up on their pressors. Maybe there's a tubing kink. Improper return cannula position. Decreased circulating volume. So hypovolemia, improper venous cannula position, could have a tubing kink again. So our pumps are non-occlusive, which means there's nothing in the pump that will stop the blood from moving in either direction. The only thing that prevents the blood from going in the reverse direction is the speed of the pump. So we don't set the speed any less than 1 liter per minute of flow, so in order to prevent the backwards flow. Also, RPMs should be set greater than 1,000 in order to reduce the risk of clot formation and backflow. Moving on to gas flow, check for color difference between the arterial and the venous blood. Of course, arterial blood should be brighter than the venous blood. If your patient is on VV ECMO and is on a sweep trial, there is no gas flowing through the blender. So the blood is going to be venous on both sides of the oxygenator. That means the blood is going to be dark on both sides of the oxygenator. Make sure the FO2 and the sweep are set correctly. Check that the gas tubing is not kinked and that it is connected from the blender to the oxygenator. In the example I've provided, the sweep is at 1 liter and the FO2 is set at 60%. So for circuit integrity, you're going to check for clots, fibrin strands, air, and leaks. Clots will appear dark red. Quite often we'll find them in the corners of the oxygenator because it's square, and clots are usually found in areas of slower blood flow. Also, commonly we'll find them at connector sites. Fibrin strands, again, you'll find those in the oxygenator and at connector sites. It's not unusual to see it, but not all patients will have fibrin strands. Air bubbles are never normal in an ECMO circuit. Please call us right away if you see bubbles. If you see a massive air bubble, clamp out the circuit and call us. If they're tiny little air bubbles on the pre-membrane side, so the venous side of the oxygenator, you can continue with the ECMO therapy. Let us know and we can, what we call, burp the oxygenator. We can take the yellow cap off and disperse the air bubbles back into the air because there's a one-way valve under that yellow cap. We ask that you don't do that. We'll do that, but if you see air, always let us know. As well as leaks and cracks, of course, those are never good and never normal in any circuit. If the leaks are big enough and enough blood is coming out of them, please clamp out the circuit. So you're going to check your cannulation sites just as you would with your IV sites. You're going to note, is there bleeding around the cannulation sites? Is it new? Has it been bleeding? Is it worse? Is it getting better? It's not unusual for our patients to bleed at the cannulation site, especially if they're immediately post-op. Do the dressings need to be changed? So are they bleeding enough that the dressings need to be changed? Are they bleeding enough that the surgeon needs to intervene? Is there skin breakdown, redness, edema, heat at the insertion site, or at the sites where the tubing has been secured to the skin, usually with sutures? Anticoagulation. All of our patients on ECMO will be anticoagulated. They may not be the first 12, 24 hours, especially if they're post-op and they've received quite a bit of anticoagulation intraoperatively. Most often the patients will be on a heparin drip that will then target a PTT between 50 and 70. So even if the patient is properly anticoagulated, it is not unusual to still find small clots, especially on the pre-membrane side of the oxygenator or the venous side of the oxygenator. That's not unusual. Again, fibrin strands will be found as well, and that won't be unusual. Something's gone wrong. Now what? Call perfusion. There's always at least one of us around, and we will come immediately. Always call an RT, especially if the patient is dependent on ECMO for gas exchange so that they can take over ventilation right away. And always call a doctor. What do we want you to do in the meantime? We want you to clamp out the circuit if you see massive air on the pre-oxygenator side and any visible air on the post-oxygenator side. So the part of the circuit that is returning the blood to the patient should never have any air in it. If they do, clamp the line out before the air gets to the patient. If a cannula has come out, clamp it. Clamp wherever you can so that the patient doesn't exsanguinate. If the circuit has become disconnected, same thing. Clamp it so the patient does not become exsanguinated. If the pump head fails, the cone is not spinning for some reason, whether there's no power or the machine is broken or whatnot, we need to put the pump head in the hand crank and hand crank it. You do have co-workers who have been taught how to hand crank. We haven't taught everybody how to do this, so please know who you're working with who can hand crank if you are caring for the ECMO patient. Clamping the circuit. Do not clamp wire-reinforced areas of the cannulas. Most, if not all, of the cannulas we use for ECMO are wire-reinforced. This helps to prevent kinking of the cannulas in the patient. However, if you clamp them, the wire will crush and it will stay that way, and most likely we'll have to exchange the cannula for a new one. The other thing is, do not clamp connection sites. Connectors are plastic, and if you break off a piece of the plastic, it becomes an emboli, which can seriously harm the patient. The other thing is the connectors could crack and the circuit could start to leak. So you might ask, so where can we clamp on a cannula? Well, the last little bit of every cannula, it's probably about 4 or 5 inches, has no wire reinforcement. So if you put a thumb width between the wire reinforcement and the clamp, you're safe. Again, with connection sites, if you put a thumb width distance between the connection sites or connectors and the clamp, you're safe. The other thing is, only ever use tubing clamps. On many occasions I have found regular clamps which have very sharp, jagged teeth hanging on the ECMO pump. I've also come across OR scissors hanging on the ECMO pumps. If in an emergency those are grabbed instead of tubing clamps, they will go through the tubing and you're going to be in a bigger mess than what you were when you started. So please make it a habit to check that you have 4 tubing clamps hanging on the circuit in case of emergency. Please, if you find regular clamps or ones with sharp teeth on them or scissors or anything else hanging on the ECMO, take it off because you'll regret it if you don't in an emergency. Regular clamps, or the ones that have sharp teeth, can be used to secure the tubing to the bed, but should never be put on the ECMO circuit because a warm ECMO circuit tubing will rip apart with regular clamps. If you don't know what the difference between a regular clamp and a tubing clamp looks like, please feel free to ask any of the perfusionists or any of your more experienced co-workers. So just for your own safety, please, again, make sure there are no scissors and no sharp clamps hanging on the ECMO pump at any time. So in addition to ECMO, we can also have VAD patients. VAD stands for Ventricular Assist Device. It's a mechanical device that supports a ventricle. So you can have an LVAD, which supports the left ventricle. You can have an RVAD, which supports the right ventricle. Or you can have two VADs, one for each ventricle, which we call a BiVAD. A VAD circuit looks a lot like an ECMO circuit. Mind you, it won't have an oxygenator, and because it doesn't have an oxygenator, it won't have a heater. And the monitoring for that is the same as for ECMO. That concludes the presentation. Hopefully I've given you enough information to cover the basics and get you started. If you have any questions, please don't hesitate to ask me or any of the guys I work with. Everybody on the perfusion team here is happy to help whenever we can. Thank you.